welcome back to hematology. In our last lecture and a couple previous lectures, we've talked about classifying anemia based on MCV and MCHC. We know that according to our MCV, we can have microcytic anemia, macrocytic anemia, or normocytic anemia. And for those of you who have been with me for a while, you know I love a good recap. So here is our recap. Anemia, of course, is a decrease in the ability of blood to carry oxygen to the tissues due to decrease of hemoglobin or erythrocytes. So ultimately, if we do not have enough hemoglobin to bind to that oxygen, or we don't have enough red blood cells which contain the oxygen, we might suffer from hypoxia. We may develop if red blood cell loss or destruction exceeds the bone marrow's ability to produce red blood cell, or if there's something going wrong imperatively within that bone marrow. And again, anemia is not necessarily a disease, but it is an expression of some underlying disorder or disease. Patient history, physical exam, and laboratory testing aid in the diagnosis. Okay, so let's just review our laboratory investigation with regard to our hematology testing. We have our CBC, which is the complete blood count, and that, of course, is our initial screening test. This is often where anemia is discovered. And, of course, our red blood cell indices, our MCV, our MCH, and our MCHC. Now, we also have a couple of others. We did talk about our RDW in the past lectures. So this is just a quick review. And remember, our MCV, our MCH, and our MCHC are all calculated values. So make sure you know those calculations if you have to extrapolate that from information that you may have. So we did talk about our RDW, which is our red cell distribution width, and that is also a calculated index to identify the amount of red blood cell size variation. Remember that anisocytosis. Our normal RDW is less than 14.5, and the higher the number, the more variation we are going to see. And we can actually visualize that as we discussed earlier on the slide. Reticulocyte count is going to give us the number of reticulocytes that are present. These are immature red blood cells, remember, that contain an increased amount of residual RNA. And this is going to help us indicate the effectiveness of the bone marrow's compensation with regard to its red blood cell production. And of course, we use this, it's a really helpful tool for physicians to utilize when providing a course of treatment for people who are anemic, and this will help us determine whether or not the therapy is working. We have our peripheral blood smear exam, where we look at the red blood cell morphology with regard to our red cells, and that is helpful in diagnosing types of anemia. And then later on, we'll talk about our white blood cell counts and go into more depth with that. And then last but not least, we can also evaluate bone marrow through our bone marrow aspiration. And this can also help with diagnosis when other lab tests are inconclusive. So a lot of times what we see is a reflection of the bone marrow or a reflection of the peripheral blood is going to give us kind of an idea of what's happening in the bone marrow. And a lot of times we can visualize things in a bone marrow slide that we can't necessarily see in the peripheral blood because we're looking at the precursor cells, remember, and we can see if there's anything going wrong with them developmentally. We can look at iron storage, etc. Although our primary focus in this course is hematology, it's important to recognize that every department within the laboratory has to work together to aid in providing information and scientific data to physicians to aid in the diagnosis of our patients. So some of the other tests that can be performed by other departments aside from hematology with regard to the diagnosis of anemia are, we may go to chemistry for bilirubin, hemosiderin testing, haptoglobin testing, LDH, ferritin, transferrin, and we might also do a DAT or a direct antiglobulin test or direct Coombs test um, in our immunohematology department or our blood bank department. So all of these tests can also aid in determining the presence of anemia and the cause of anemia. I've briefly introduced to you in earlier lectures some of the causes of different types of anemia and how we classify them utilizing our MCV and our MCHC. Now let's break it down into each category and talk about the different types of anemias that we might find. Let's start with our microcytic hypochromic anemias. And remember, microcytic is going to be referring to our MCV. This would indicate that our MCV is less than 80 femtoliters, and hypochromia would be an MCHC of less than 32. One of the kind of broad areas that we see anemia fall under with regard to microcytic hypochromic anemias are anemias of defective heme synthesis. Now, defective hemoglobin production might be due to disturbances in either the heme group or the globin chains and their synthesis. It could also be caused by lack of iron or abnormal iron metabolism. So there might be times when we have enough iron, but it's not being transported or implemented into that hemoglobin molecule the way it needs to be. So let's talk about distribution of those iron-containing compounds in the body. So our functional units are going to be our hemoglobin, but we also have myoglobin, which is going to be an important component within the muscles. We have iron transport proteins called transferrin, and then we have the storage of iron in the forms of ferritin and hemosiderin. Now, ferritin is going to be found at various points throughout the body. It is more readily available for use when needed. And then hemosiderin is kind of that long-term storage. So I always kind of think of it as ferritin is the warehouse where the transferrin comes to transport the iron, and then hemosiderin is the point of production where it is in long-term storage and then is sent to the warehouse where the ferritin is. We also need proper absorption of iron, and that's going to be dependent upon a few things. Maybe the amount of iron that is ingested. So it could be that someone who is depleted in iron is not ingesting enough nutritional nutrients with iron. The form of iron is ingested. So remember, we want our iron to be in that ferrous state and not the ferric state, because ferrous is much better absorbed. It's easier for our body to utilize. And then the iron balance of the individual. So it could be a person who has an increased demand. So babies, women who are pregnant, growing teenagers, athletes, women in their childbearing years in general, due to menstruation and those taxing physiological processes that are happening. So transferrin transports iron to the bone marrow and releases it to those developing red blood cells. So transferrin transports. That's kind of how I remembered it when I was a student. Transportation of iron. And then our iron storage. So again, ferritin is that primary storage and it's readily released, but then that hemosiderin is in the bone marrow and it is long-term storage and has a slower release. If a person is to have been found to have a decreased hemoglobin or anemia, we want to find out the cause of that so that we can treat the patient and correct that anemia. So we might do some laboratory iron studies. These are going to take place within the chemistry department. The very first thing we're going to do is we want to know, does the patient have enough iron? So we will do a serum iron level, and we're going to be measuring the iron that is bound to transferrin. We might also directly measure the transferrin. We want to make sure that we're not deficient in the transport proteins of iron. And then we might look at a total iron binding capacity, also known as a TIBC. It's a functional measurement of transferrin and the capacity of iron to bind to transferrin. So this kind of has an inverse relationship to iron. So as iron within the serum increases, our TIBC decreases because the more serum iron that we have, it binds to the transferrin, leaving open fewer binding sites. And that's what we're measuring, are the actual binding capacity. So if they're filled up, then that TIBC is going to decrease. And then if we have a decreased serum iron level, we will have an increased binding capacity for iron on that transferrin. Next, we could measure our transferrin saturation, and that's going to measure what percent of our transferrin is saturated. And there is a calculation that goes along with that. We're going to take our serum iron level divided by our total iron binding capacity and multiply that by 100. And that's going to give us a percentage. Next, we're going to look at our serum ferritin. We want to know, do we have enough ferritin in the body? And it should be proportional to the amount of storage iron in the body. So this is going to tell us if we have substantial decrease in ferritin or if we have a proper amount. The next test that we might do in our iron studies is our soluble transferrin receptor assay. This will help us differentiate iron deficiency anemia due to lack of iron from anemia of chronic disease. And then our zinc protoporphyrin, or our ZPP, will measure the excess protoporphyrin when iron cannot be incorporated into the protoporphyrin ring. So remember when we talked about hemoglobin production and we had that point at which the iron is inserted into that protoporphyrin ring during development? If something's going wrong during that point in development, we might have enough iron, but we don't have hemoglobin that is functional. And so that zinc protoporphyrin is going to help us measure whether or not something's going awry at that point in development. The most common cause of microcytic hypochromic anemia is iron deficiency anemia. You might hear it called IDA. And usually the most common cause is iron deficiency due to inadequate intake or poor diet. It could be due to increased requirement, so rapid growth, childhood, adolescence, pregnancy. It could be due to blood loss, either through menstruation or a GI bleed or some kind of chronic bleeding disorder. And it might also be with treatment of erythropoietin. So remember, erythropoietin is that hormone that is released by the kidneys, primarily by the kidneys, that stimulates our bone marrow to prioritize the production of red blood cells. Now, if we are being given erythropoietin and we're producing a higher than normal amount of erythropoietin, it might be that the iron intake that we have is not keeping up with the demand of that erythropoietic process that is stimulated by the erythropoietin that we are being given. We may also have malabsorption syndromes, SPRU, which sometimes people will call celiac disease, gastritis, gastrectomy, so people who've had gastric bypasses. There might be some malabsorption there, which would lead to an inadequate amount of iron being absorbed. Of course, like most conditions, iron deficiency anemia doesn't occur or pop up overnight. Usually it is a slowly progressing condition. So let's talk about some of the stages of iron deficiency and how it can lead to iron deficiency anemia. The first stage of iron deficiency anemia, or iron deficiency in general, is iron depletion. And this is where iron stores are used up And it's indicated by decreased ferritin. So this is typically what we see in when we have an increased demand and we're not having enough iron intake. The second phase of iron deficiency is iron deficiency erythropoiesis. And this is where now we've utilized up all of that storage within the ferritin, and we're starting to see some effects within the erythropoietic centers of our bone marrow. We can easily take a look at our serum iron levels and our percent saturation. Both of those will be decreased. And then our total iron binding capacity, our STFR, and our ZPP will increase. Iron deficiency anemia is the end point. Our hemoglobin is now decreased. We have now achieved a microcytic hypochromic red blood cell morphology that's present, and we now have iron deficiency anemia. When evaluating patients prior to diagnosis, we want to look at some of the clinical signs and symptoms. And there are a few clinical signs and symptoms that are very specific to iron deficiency anemia. The patient is typically going to feel fatigued. We may see koilonchia, which means concavity of the nails, so kind of a scooping nail shape. We may see an inflamed tongue, which we call glycitis. Pharyngeal webs in the back of the throat. Sometimes muscle dysfunction. Now remember, muscles need oxygen. They need myoglobin, which helps them function, and that is also dependent upon iron. And if that is inadequate, muscle dysfunction is very common. They may also have the inability to regulate body temperature. Now remember, hemoglobin carries oxygen. It also carries waste away from cellular metabolism or metabolic processes. So it's really important for all of our metabolic processes to have everything kind of working together. And if oxygenation is depleted due to low hemoglobin, those metabolic processes can go awry. We may see gastritis. And then kind of something that's we see a lot in patients with iron deficiency anemia is called pica. And this is an unusual craving for ingesting unnatural items as food. So sometimes people will crave dirt or chalk, and even sometimes things like ice can be an indication of iron deficiency anemia. So like with any scientific method, we have to actually prove our diagnosis to the best of our abilities with scientific data. When evaluating iron deficiency anemia, we've done our hematological tests, we've done some of our chemistry tests, but let's kind of walk our way through those again. So some of the laboratory evaluations, again, we're going to look at that peripheral blood smear. What we might find with regard to our red blood cell indices is a decreased RDW. Remember, we're going to have a lot of variation in those size of cells, that anisocytosis. We will see microcytic hypochromic RBCs. We might see morphologies like target cells, ovalocytes, perhaps teardrops, and a decreased reticulocyte count. Now, you might ask yourself, why are we seeing a decreased reticulocyte count? Well, think about it. Reticulocytes are the bone marrow's way of indicating that they are compensating for either red blood cell loss or increased need. And if we do not have the building blocks to produce more reticulocytes or more red blood cells, we aren't able to compensate. So this would be an indication of decreased bone marrow compensation due to lack of iron. We are going to look at some chemistry tests. So we've talked about iron studies, which will see a decreased serum iron, a decreased ferritin, decreased transferrin saturation, and an increased TIBC, STFR, and ZPP. At this point, the doctor may decide to do a bone marrow biopsy so that he can see what's happening within, he or she may see what's happening within the bone marrow. We will get a bone marrow biopsy, put it onto a slide, and we will inspect the red marrow or the spicules of those hematopoietic areas of the bone marrow. utilizing a Pearl's Prussian blue stain. So this is another one of our supravital stains, and it is very specifically used to show iron stores in the form of those hemosiderin in the macrophages of the resident macrophages of the bone marrow. Now, if we obtain a bone marrow biopsy, we stain it with that Pearl's Prussian blue stain, and we don't see any hemosiderin, we know that the patient is very, very significantly depleted and has no iron storage at all, or very, very low iron storage. We may see iron in various amounts, which can kind of give the physician an indication of how severe this iron deficiency anemia is, and then they can decide upon a treatment or therapy. Now, we also want to find the cause as well as treat the underlying disorder. Usually, anemia and iron deficiency responds well to oral ferrous sulfate. But if the patient is having a lot of clinical presentation or clinical health side effects, we might actually do a blood transfusion or a red blood cell transfusion just to alleviate the patient's discomfort while their body begins to rebuild that iron storage. Sometimes, if it's very severe, we will also do an IV iron infusion. Well, iron deficiency anemia is caused by lack of building blocks, in this case iron. Sometimes anemias, microcytic hypochromic anemias, are caused by abnormal iron metabolism, and this can occur in something called sideroblastic anemia. This is not due to a lack of iron, but rather the inability of the iron to be inserted into that protoporphyrin ring to form that heme of the hemoglobin. Typically, this is hereditary. It could be a rare sex-linked and recessive form, but often it can be acquired, and this is usually associated with something we call refractory anemia with ringed sideroblasts. It could be secondary to drugs or toxins, and this is really common when we see with lead poisoning. It could also be part of a malignant condition. Lab features. In our peripheral blood, we are going to see dimorphic or dual populations of normochromic, so our MCHC is going to be normal. But also we are going to see populations of hypochromic cells. So we're going to have some cells with a normal MCHC and some cells with a decreased MCHC. With the it will obviously be calculated because we talked about that the MCHC is calculated. So it could look like a normal MCHC, but then when you're looking at the morphology, you see that dual population depending upon the number of red cells that are normochromic versus hypochromic. We may see Pappenheimers, those Pappenheimer bodies, which are iron deposits. Remember, we talked about those in our morphology lecture. And basophilic stippling. Now remember, ringed sideroblasts or sideroblastic anemia is really common because lead poisoning can interfere with the distribution and the incorporation of that iron. And so that basophilic stippling is also highly prevalent when we have cases of lead poisoning. And again, remember, this is precipitated RNA, which is characteristically found in patients with lead poisoning. It can occur in other conditions, but this is a hallmark of lead poisoning. We, again, are going to do our iron studies. We'll look at our serum iron, our ferritin, and percent saturation, and they will all be increased. So now we are looking at the other end of the spectrum where we have an increased iron. And of course, as we intake iron, we aren't able to insert it into that heme appropriately. So it just kind of builds up. We can't utilize it, so it's not going anywhere. And so that's why we would have an increase in all of the components of our iron studies. If a physician were to do a bone marrow biopsy, what we would see are ringed sideroblasts. And I'm going to show you a picture of that here in just a minute. These are formed when iron granules are abnormally accumulated around the nucleus of those maturing red blood cells. So remember, ferritin typically distributes that iron to those resident macrophages within the bone marrow, or those siderophages, and they then allow that iron to be implemented into developing red blood cells. And what we see instead are kind of an abnormal presentation where we have these developing immature red blood cells in the bone marrow, and instead of having like a normal appearance, they have just a ring of blue iron around them. And remember, we have to look at that bone marrow with that Pearl's Prussian blue stain in order for us to diagnose that sideroblastic anemia. We're also going to be looking for at least 15% of our immature red cells to have that ringed sideroblast presentation. Of course, we're going to want to find the reason for this sideroblastic anemia and eliminate that drug, that toxin, or whatever's causing it. Now, patients with hereditary sideroblastic anemia are a little bit harder to treat, but most of the time with refractory anemia or lead poisoning or drug exposure, we can eliminate some of those things to treat the patient. Right, in this picture, um, this is a picture of the bone marrow. It's kind of a close-up picture because I really wanted you to be able to get a good representation or good view of that. And all of these cells here are immature red blood cells in varying stages of development. And this has been stained with a Pearl's Prussian blue supravital stain. And all of these blue granules are in a ringed form. And this is what we would see in a ringed sideroblastic anemia or a sideroblastic anemia. We want to see these ringed sideroblasts. Other anemias caused by abnormal iron metabolism may be anemia of chronic disease. This first one is seen in patients with chronic infection and inflammation. Could be due to neoplasm, and it may be due to cytokine inhibition of erythropoiesis. So ultimately, we are going to see an increase of erythropoiesis because there's some type of kind of communication problem. Remember, our bone marrow communicates the need via those cytokine and hormones that are utilized to kind of like trigger the bone marrow's prioritization of what kind of cells are needed at any given time. It could be due to blocked iron release from those macrophages that are storing, those siderophages that are storing the long-term storage of iron, or it could be due to shortened red blood cell survival. So some of those lab features that we may see are normochromic normocytic anemia. So in this case, we're going to have a normal MCV and a normal MCHC. We may have decreased iron, TIBC, transferrin saturation. We may have a normal ferritin and STFR with an increased ZPP and an increased hemosiderin in the bone marrow. Usually therapy is aimed at treating the underlying disorder. So in this case, so there could be, let's say, for example, there could be either an increase of erythropoietin or erythropoiesis or decrease depending on what the chronic disease is. So it could be kidney dysfunction. So maybe there's a lack of erythropoietin, and therefore less erythropoietin is produced, meaning bone marrow is not signaled that it needs more red cells, and so inhibition of erythropoiesis occurs. It could be in the case of some red blood cell proliferation we might actually have an overload of iron or red blood cells. In the case of maybe where there's a gene mutation that kind of hijacks the erythropoietic signals. So in the case of the anemia, though, we'd be looking at more of a decrease of erythropoiesis due to something like liver or kidney dysfunction. Because remember, there are erythropoietic centers and there is some responsibility of the liver as well as the kidneys. But let's talk about another condition. It's not exactly an anemia, but it is a metabolism disorder when it comes to iron, and that is called hemochromatosis. Hemochromatosis is typically a inherited disorder, and we suspect this when iron studies suggest an iron overload, where we have an excess of iron that's deposited in the tissues. It's not really associated with anemia, but I did throw it in here because it is caused by an abnormal iron metabolism, and it's something that you may hear. So these patients would have to have therapeutic phlebotomy where they alleviate their body from some of that blood volume just to deplete the iron levels, simply because iron in such excess can be really detrimental to a person's health. Okay, so we know that hemoglobin is made up of both heme and globin chains. And we've talked about some of the things that can go awry with implementation or lack of iron in the heme portion. But now let's talk about anemias of defective globin synthesis. Now, the abnormalities of globin synthesis can occur in either the alpha chains or the beta chains. And remember, in adult hemoglobin, normal adult hemoglobin A, we have those two alpha chains and those two beta chains, right? So when we have a defective globin synthesis, this is what we call a thalassemia, and that is a result of a genetic defect that produces or reduces the production of normal globin chains. So this is a quantitative disorder. So gene deletions are responsible for a depleted number of globin chains that are synthesized or able to be synthesized. So let's go back and review kind of what our normal adult hemoglobin looks like. In a normal adult, we have the prevalence of hemoglobin A, which again consists of two alpha chains and two beta chains, and that's going to be about 95 to 97% of our normal adult hemoglobin. We are going to have a small amount of hemoglobin A2, where we have two alpha chains and two delta chains. And this is going to be between 2 and 3% of our normal hemoglobin. And remember, we're still going to have a tiny, tiny bit of that hemoglobin F, or that fetal hemoglobin that carries over from fetal development, and that is comprised of two alpha chains and two gamma chains. This typically is comprised of less than 2% of normal adult hemoglobin, and is, of course, the major hemoglobin of the fetus and newborn in various stages of development. The first type of thalassemia that I want to introduce you to is called alpha thalassemia. Now, alpha thalassemia affects the alpha globin chains. And this is where we have 1 to 4 of those alpha globin chain genes, which may be deleted and may cause an absence or decreased production of alpha chains. Now, if you go back and you look at all of the hemoglobin types, all of them have alpha chains, all of them. Now, it's a second set of chains that typically varies depending on the type of hemoglobin, but every single type of hemoglobin have alpha chains. So in alpha thalassemia, depending on the number of deletions for those alpha chains is going to kind of determine the severity of our alpha thalassemia. So let's talk about the first one. The first type of alpha thalassemia is called hydrops fatalis, and this is a deletion of all 4 alpha chains. That means it is incompatible with life because there can be no hemoglobin formed without alpha chains. There may be an excess in gamma chains that form tetramers. So instead of having 2 Alpha gene or two alpha chains and two gamma chains will just have four tetramers of gamma chains, and we call that hemoglobin Bart's or Bart's hemoglobin. You might hear that as well. And that's associated with that hydrops fatalis. The second type of alpha thalassemia is called hemoglobin H disease, and this is where we have three of our four alpha genes deleted. We might see excess beta chains that form hemoglobin H, and this is going to cause mild to severe anemia, really depending on your pattern of inheritance. And then our alpha thalassemia trait is where we have two of the four alpha genes deleted, causing mild anemia. If we have only one alpha gene deleted, we call that silent carrier. Most of the time, this patient is going to be asymptomatic, but they do carry the capacity to pass that genetic information on to their offspring, which, depending upon the other parent's pattern of inheritance, the child could end up with an alpha thalassemia. And of course, we have our beta thalassemia, which is going to be associated with abnormal beta chain genes. It could cause an absence or a reduction in normal beta chains. We kind of classify this into two categories. We have thalassemia major, which is a homozygous form of inheritance, which results in a severe anemia, and it can cause an increased erythropoiesis. So the reason for that is because when the body, remember we talked about hypoxia, when the body recognizes hypoxia or lack of circulating oxygen, it is going to trigger the bone marrow to become more active. And what happens in thalassemia major is there's a constant perpetual form of hypoxia. And so that bone marrow is continuously stimulated and will try to compensate because our body does everything it can to compensate when we are depleted in any way. And unfortunately, because of that, we see expansion of the bone marrow space, and especially in the flat bones, leading to skeletal deformities. A lot of patients who are not diagnosed or who lack the accessibility to healthcare, we see facial deformities in those flat bones of the face and head um, because of that bone marrow expansion. And it can cause to even more skeletal deformities the more uh, as a patient gets older, and if that beta thalassemia major is not treated. Now, what we can do is we can treat these patients with transfusions and then iron chelation just to prevent that iron overload, because as we're adding more red blood cells in, we're also adding iron in. And remember, these patients are not iron deficient. They just have a decrease in those beta thalassemia or those beta chains so that they aren't able to produce enough functional hemoglobin. The second category of our beta thalassemia is going to be thalassemia minor. This is typically a heterozygous pattern of inheritance, and these patients will often form a mild anemia. And beta thalassemia minor and iron deficiency anemia are pretty much very often confused one with another. So a patient may have beta thalassemia minor, but um, upon initial investigation, we may think that it could be iron deficiency anemia. They're very, very similar in terms of their presentation, and it's really further testing that helps us differentiate between that beta thalassemia minor and iron deficiency anemia. So I'm not going to dive too deeply into our alpha thalassemia. The important thing to know is the type of deletions that are there, and know that it's a quantitative disorder of our alpha chains. Beta thalassemia is much more prevalent, and so I kind of want to go into other laboratory findings that are associated with beta thalassemia. And the reason for this is because, as I mentioned before, iron deficiency anemia and beta thalassemia are very difficult to differentiate one from another without further laboratory testing. So some of the findings that we may come across with regard to beta thalassemia is we may have, with regard to our hemoglobin, normal to severely decreased hemoglobin, depending on the severity of the genetic defect. And remember, all of these pattern of inheritances Although they affect the beta chains, there are going to be some that are more severe and some that are less severe, depending on the extent of that gene deletion or defect. We're going to have some low red blood cell indices, so our MCV is going to be markedly decreased, so they will be microcytic. And it may be helpful in distinguishing thalassemia minor from iron deficiency anemia, only because usually our although our iron deficiency anemia is also microcytic, it might be even more so with beta thalassemia. But not always. Sometimes that's, depends on the case. Our RDW should be normal in thalassemia minor, but it may be increased with thalassemia major. So when we are looking at a beta thalassemia minor versus major, there's going to be some different populations present depending on the presentation of being minor or major. And then our peripheral blood smear, again, we're going to have those microcytic hypochromic red blood cells. And I want to make a point here. When evaluating smears, there are sometimes hallmark cells that are very highly associated with certain conditions. And in the case of beta thalassemia, our hallmark cell are those target cells. You often, almost always see target cells with beta thalassemia. Now, you may see target cells in things like iron deficiency anemia, but you almost always see it in beta thalassemia. So I like to say that the target cell is a hallmark cell of beta thalassemias. Um, but because of those abnormal morphologies, remember, we are going to have kind of rapid cell breakdown or a more, I guess, a premature breakdown of some of our red cells. We might have nucleated red blood cells in circulation, and we may also have basophilic stippling. Now remember, basophilic stippling is usually associated with lead poisoning, but it can be found in other conditions as well. We usually have an increased reticulocyte count, which is the opposite of what we see in iron deficiency anemia, because remember, we have a decreased reticulocyte count in iron deficiency anemia because of lack of building blocks, and in that case it's iron. Here we have plenty of iron, and so our body is trying to compensate for that hypoxia and for the breakdown that's occurring in the spleen when those abnormal morphologies come through those splenic cords. So how do we really prove that this patient has beta thalassemia? Because remember, in science, we have to have scientific data to back up our theories and our diagnostic suspicions. And in this case, hemoglobin electrophoresis is going to be our gold standard of diagnosis. So what we will find on our hemoglobin electrophoresis, we will be able to separate the types of hemoglobin through electrophoresis. We will have increased levels of hemoglobin A2, fetal hemoglobin, hemoglobin H, Bart's hemoglobin, etc., depending on the type of thalassemia that we have, okay? Now, osmotic fragility is decreased in thalassemia due to the presence of those target cells, because remember, we've got that increased cholesterol within the cell membrane, and therefore it's more, it's kind of structurally more sound with regard to the influences that those fluid forces can have. And so osmotic fragility is decreased, and that is also useful in screening for thalassemia carriers because they may have the presence of target cells without the clinical signs and symptoms of the thalassemia other than just the morphology. We're going to look at our iron studies as well, the same ones that we would utilize when evaluating iron deficiency anemia, and in this case our iron studies would be completely normal. Okay, so now we have talked about some of the causes of our microcytic hypochromic anemias. Let's move on to our macrocytic anemias. Now remember, macrocytic is going to be referring to our MCV of greater than 100. We don't associate macrocytic anemias with the MCHC per se because remember, there's no such thing as hyperchromic. So usually macrocytic anemias will be normochromic. Um, but there can be a variety of different causes. So let's kind of talk about those moving forward. Okay, so as I mentioned, macrocytic anemias typically have red blood cells that are larger than with an MCV of larger than 100 or greater than 100 and a normal amount of hemoglobin. So macrocytic normochromic. Um, but the funny thing is about macrocytic anemia, there can sometimes be things that are happening within the production of red blood cells that can be associated with different conditions or different deficiencies. So when we talk about the production or the process of production, we call that blastic. So we can have normoblastic, which means normal development, or we can have megaloblastic, which means there's something causing those cells to go awry during development. So something during development is causing them to be larger. Let's first talk about megaloblastic anemia. So megaloblastic anemia is typically caused by a nuclear maturation defect caused by impaired DNA synthesis. That's interesting. What would cause an impairment of DNA synthesis? Well, vitamins B12 and folate are both required for normal DNA synthesis. And when we have a decrease on either of those nutrients, impaired synthesis leads to delayed nuclear development. So let's think for a minute about what happens during cellular development. So as a cell prepares to divide, we have an increase in cytoplasmic development. So we increase the amount of cytoplasm as we're preparing for nuclear enlargement so that we can divide into two sister cells, right? What happens in megaloblastic anemia is we'll have that cytoplasmic development, so it grows larger in size. And then when it comes to the DNA synthesis that is needed for that nuclear development and enlargement, it just can't quite do the job because it's lacking or it's impaired in its synthesis of the DNA. So what will happen is we'll have this these really large cytoplasmic areas, and then the cell will get to a point where it really can't divide appropriately. So we call this cytoplasmic or nuclear to cytoplasmic asynchrony. And this is a really important term to remember. That nuclear to cytoplasmic asynchrony is just really going to be one of those bone marrow indicators that we are looking at a megaloblastic anemia. And it's usually associated with B12 or folate deficiency, sometimes one, sometimes the other, and sometimes both. So at this point, red cells don't develop properly and end up just being larger than normal. So you have this large cytoplasm expansion, nucleus cannot keep up, it can't do its job, and then it ends up either not separating or you just have a smaller than normal nucleus with this large cytoplasm. And at that point, when they are released from the bone marrow into circulation, they are still larger than they would ordinarily be if they had a normal DNA synthesis. As we've mentioned before, when a patient goes to a physician, the very first thing that a physician is going to look at are the clinical signs and symptoms of the patient. Now, in macrocytic anemias, we see some of the same symptoms that we see in other types of anemia. We see, for example, lethargy, weakness, yellow pallor. We may see glossitis, which is that inflammation of the tongue. But something that we see in macrocytic anemias that are kind of specific are neurological symptoms. And this is specific to B12 deficiency, not necessarily folate deficiency. We might have tingling, numbness, and weakness in the extremities. And that's because when you think of our nervous system, there's constant renewal of the cells that support our nervous system, and all of the cells in our body require DNA synthesis for repair, for reproduction, all of those things. And B12 is going to affect not just our red cells, but every type of cell in our body because we need that DNA synthesis to be happening appropriately. One thing that we don't really see too often anymore because of the advances in medical care that we have is something called megaloblastic madness. And of course, that's named for the severe psychological disturbances that are seen in B12 deficiency. Um, it used to be much more prevalent in the past, but we don't usually see it now because vitamin B12 deficiency and macrocytic anemias are more easily diagnosed now. In the past, when people didn't have access to um, dietary supplements, or people maybe who were very poor didn't have access to meat or animal products in the amount that would be necessary for B12 supplementation or nutrition. This could have been a problem for people who are very impoverished in the past, but hopefully we don't see that these days. And I don't think I've ever seen a case since I've been working in the healthcare field. Okay, so let's talk about our laboratory findings. Remember, we have to have scientific data to back up um, our suspicions diagnostically. So let's talk first about our peripheral blood and what we might find in that peripheral blood smear. Again, our MCV in these macrocytic or megaloblastic anemias are greater than 100. Our MCH is going to be increased because of that large cell volume, and then we'll have a normocytic MCHC. We are going to have a decreased hemoglobin and red blood cell count. Why would we have a decreased red blood cell count? Well, again, if we aren't having proper DNA synthesis occur, we cannot produce the number of cells necessary. And so the other thing that we're going to see is something called pancytopenia. That means a decrease in all three cell lines that we would find that would come from the bone marrow. So our white blood cells would be decreased, our red blood cells would be decreased, as well as our platelets. Because remember, every single type of cell in the body requires proper DNA synthesis. Not only are we going to see morphology changes in our macrocytic megaloblastic anemias, we are going to see morphology in the white blood cells as well. This is the one anemia, the one type of anemia that affects morphology of both white cells and red cells. So our red cells are going to be maybe oval macrocytes. We might see Howell Jolly bodies. Remember, those Howell Jolly bodies are the round inclusions that look like little belly buttons. Those are made of residual DNA. And if you have a process going awry with regard to DNA synthesis, you may have little bits of DNA left over. And then we are going to also see hypersegmented neutrophils, greater than 5 lobes, so or greater than 5 segments. So if you look here at this neutrophil, we have 1, 2, 3, 4, 5, 6 segments. Normally we have 2 to 5 in a normal neutrophil, and here we have 6. Could even be more than that in some cases. Over here we have that Howell Jolly body. We've got one up here, it's just not as apparent. And this is what we would call a macrocytic ovalocyte or a oval macrocyte. Either one of those terms is appropriate. All because of that DNA synthesis abnormality. Okay, so not only are we going to see changes in our peripheral blood, we are going to see some bone marrow issues. So the first thing we're going to notice about our bone marrow is that we have a hypercellularity, meaning more than normal cellular production. Now, I know I said that what we find in peripheral blood is pancytopenia. Yes, that is true. But we're going to have an increased production within the bone marrow because, of course, we're trying to compensate. So we have an increased cellular component of the bone marrow, but also an increased erythroid precursors. Now, a lot of these precursors are going to be megaloblastic, where we have that nuclear maturation. that lags behind the cytoplasmic maturation. Remember, that is going to be our nuclear to cytoplasmic asynchrony. Our white blood cells and platelets also show nuclear maturation defects. We might see giant metamyelocytes. We might see giant bands. And all of our cells are going to look larger than normal. We might even see megakaryocytes in a disproportional amount. Now, why would we have a hypercellular bone marrow, but we have pancytopenia outside of in our peripheral blood? Well, that's because a lot of these cells have a decreased lifespan. They don't actually make it out into circulation because when that DNA synthesis goes awry, it can affect the cell survival as well. Or the other reason might be because as those cells circulate, because of those abnormal morphologies, they might be plucked out in the spleen when they try to go through those splenic cords. If they don't fit just right, or if they're seen to have those Howell-Jolly bodies, or they're a little fat and they can't get through those splenic cords as well, then they might just get taken out of circulation by the spleen. So both of those are causes for that pancytopenia. So not only is vitamin B12 responsible or could be a potential cause for megaloblastic or macrocytic anemia, but folate deficiency as well. Let's talk a little bit about the metabolism of folic acid. You may sometimes hear it called folate. So obviously we get the majority of our folic acid through nutrition, and our liver is pretty good about storing folate to provide daily requirements. And it can store 3 to 6 months worth if folic acid is, temporarily omitted from the diet. We should be okay for about 3 to 6 months. Again, folate, just like B12, is needed for that proper DNA synthesis. And folate deficiency can affect the DNA of all of those rapidly dividing cells, like we talked about, red blood cells, white blood cells, and platelets. They all show those characteristic megaloblastic changes, just like we have in B12 deficiencies. So just like iron deficiency anemia, folate deficiency can have some similar causes. We may have a nutritional deficiency, which is just due to inadequate diet. And this is commonly seen in people who don't have access to healthy foods, or people who are unable to afford healthy foods. We also see this in people who are elderly. Their metabolism just doesn't utilize folate as effectively. But most commonly, we see folate deficiency in people who have alcoholic illness, and that is due to the liver's role in the folate metabolism. Not to get too much into the pathophysiology of that, but just know that your liver is really important for storage of folate and also metabolism. Um, it might be due to an increased requirement. So again, in pregnancy and diseases with rapid cell turnover, we utilize that folate more rapidly. We see this especially in patients who have malignancies. We have that rapid cell turnover to those malignant cells. And think about it, any type of cell, whether it's malignant or just a normal cell, they still require the same needs. And when we have a rapid cell turnover, we're utilizing the products that are needed for cell production more rapidly. We may have malabsorption, and that could be with intestinal diseases, just like we talked about with iron deficiency anemia, maybe celiac disease or gastritis. People who've had gastric bypass surgery, all those people may have a malabsorption. And then drug inhibition. So something that we're taking, some type of medication that we're taking that can inhibit the absorption or the metabolism of folate. So oral contraceptives can sometimes cause that. Some oral anticoagulants, specifically those that target those vitamin K dependent clotting factors of the liver, and anti-epileptic drugs. All of those things can inhibit our folate absorption or metabolism. So if a physician suspects that a patient may have a folate deficiency, here are some of the laboratory findings that may be present in the case of folate deficiency. We're obviously first and foremost going to test our serum folate levels, and this is usually reflective of the amount of folic acid intake over several days. Now remember, our liver can store folate for 3 to 6 months, but the serum folate is going to show what's actually present in circulation in our bloodstream, and that's usually reflective of just a short-term intake. We might do red blood cell folate, which reflects folate available when the red blood cell was maturing in the bone marrow. And it is a much better indicator of liver stores. So when we look at that red blood cell folate, we can kind of see like what has happened over the lifetime of that red cell from beginning to end. And that also will help us know about how much we have in our liver storage. Both folate levels must be decreased in order to diagnose a folate deficiency. So both our serum folate has to be decreased and our red blood cell folate. We might also check homocysteine levels, and this would be increased in the case of folate deficiency because the conversion of homocysteine to methionine is dependent on folate, and it becomes impaired, and therefore instead of having methionine, we would just have homocysteine that was unable to be converted to methionine. While both vitamin B12 and folate deficiency are both pretty common, we more often see vitamin 12 deficiency. One of the causes of vitamin B12 deficiency is a problem with the metabolism of vitamin B12. Now, vitamin B12 is most often found in foods of animal origin, and it quickly binds to the intrinsic factor for absorption in the small intestine. Now, our intrinsic factor is actually produced within the stomach cells of those parietal cells within the stomach lining, the same cells that produce that hydrochloric acid. And um, sometimes we have a deficiency or an inability to produce that intrinsic factor. If the intrinsic factor is not available to bind to the B12, it cannot be processed, and therefore we're going to have a metabolic disorder of B12. Causes of B12 deficiency, obviously, the absence or decreased amount of intrinsic factor due to gastric atrophy is the most common cause of deficiency, and we call this pernicious anemia. You might see it called PA, but pernicious anemia simply just refers to an absence or decrease in that intrinsic factor. It could be due to an inheritable disorder, so inherited pernicious anemia, but most of the time it's due to gastric atrophy, or it could be due to maybe some type of surgical procedure like gastric bypass. Any one of those things could cause pernicious anemia if it disrupts the production of intrinsic factor. Malabsorption is another one. So celiac, Crohn's disease, anything that's going to disrupt the digestion within the intestine. And then our nutritional deficiency is pretty common in vegans, specifically common in strict vegetarians or, I mean, really vegans, because you can get vitamin B12 not just from meat, but also from eggs and other animal products. And then transcobalamin 2 deficiency, which is a precursor to B12. So we've got a deficiency there, and then nitrous oxide, which is strange, but laughing gas, people who, I guess, utilize laughing gas, whether it's through abuse or through therapeutic treatment, could develop a vitamin B12 deficiency. Okay, some of our laboratory findings with regard to vitamin B12 deficiency. The very first thing we're going to look at is serum B12 levels, and we will find them to be decreased if a patient has a B12 deficiency. Again, we're going to look at that homocysteine, and it's going to be increased whenever B12 or folate is deficient because both B12 and folate are, again, responsible for the conversion of that homocysteine to methionine. Gastric analysis could be performed since those parietal cells secrete both hydrochloric acid and intrinsic factor. And if there's an absence of hydrochloric acid it could be an indirect evidence of an absence of intrinsic factor. So if your parietal cells are not functioning or if they're impaired in some ways, you may not only have just an absence of intrinsic factor, but also hydrochloric acid. And then, of course, it might be that you produce intrinsic factor, but you have an autoantibody against intrinsic factor, so it's impaired or inhibited. So we might do an intrinsic factor antibody test. So how do we know if a person has a B12 deficiency due to pernicious anemia or due to deficiency or due to malabsorption? Well, there's a very specific test that could be performed called the Schilling test. And it's a very simple test. It is a two-part test, and it kind of helps us deduce the cause of the B12 deficiency. So the first part of the Schilling test is where we will give the patient oral radioactive B12. We give them a flushing intramuscular dose of B12, and we do that to saturate all of the available B12 binding sites. We want to make sure that the patient has B12 in the body so we can track that oral radioactive B12 dose and see how much of it is being utilized and how much is being excreted. So what we do after we've given that intramuscular dose of B12 and the radioactive dose, we are going to measure the output of the urine for 24 hours, and we're going to measure that radioactive B12 that is excreted. So if we have greater than 7.5 excretion of the oral dose, then the diagnosis is a nutritional deficiency. Because now that we have kind of flooded the patient with B12, they should no longer be deficient, and we're seeing a proper amount of excretion. If, however, excretion is decreased, we're going to move forward with the second part of the Schilling test. Now, in part 2 of the Schilling test, we repeat everything that we did in part 1, but in this case, we're going to add intrinsic factor in the oral dose. Now, after 24 hours of collecting urine, if there's a greater than 7.5 excretion, then the diagnosis is pernicious anemia because we have added in that intrinsic factor that was lacking, and now we're having a proper amount of excretion. But if the excretion is still decreased, we automatically deduce that the diagnosis is malabsorption. So we have given the patient everything needed. We've given B12 intramuscularly. We've given oral B12, we've given intrinsic factor, and if they are still not processing that B12 appropriately and excreting a proper amount, then we know something's going on in the digestion and that it is not anything that we can give to them or that they're lacking. It's just things are not going working appropriately in their absorptions area. So therapy is usually aimed at replacing the deficient vitamin. Pernicious anemia is given to patients via injection because they're lacking that intrinsic factor. They can't orally digest it or process it because there's no intrinsic factor to bind to it. So B12 injections are what we use. They're the treatment of choice for people with pernicious anemia. Okay, so with regard to B12 and folate deficiency, we term those as megaloblastic or macrocytic megaloblastic anemias. And that is because there's something going wrong in production, okay? Now, another type of anemia that we might see is called normoblastic macrocytic anemia. And this is where everything in terms of the production of the red cells is normal, but for some reason they are larger in size. Now, the most common cause of a normoblastic macrocytic anemia is liver disease, and that is primarily due to increased erythropoiesis. We also may have alcoholism that is associated with that, and that could be due to folate deficiency because remember, liver disease, that would be more of a megaloblastic, but if it is a normoblastic, we might just have reticulocytosis due to a GI bleed, that liver disease again, and then toxic effects of alcohol. So all of those things could result in a normoblastic macrocytic anemia. We might also see a normoblastic macrocytic anemia with acute blood loss or hemolysis. And again, that would be due to an increased reticulocyte production and count, which we term reticulocytosis. So remember, reticulocytes are larger in size by nature because they are less mature than mature red blood cells, and therefore they would increase the MCV simply because they're larger in size. And that's what we would be looking at. They're totally normal in terms of production, totally normal in terms of um, their nuclear maturation, etc. But because of either liver disease or alcoholism, which is often highly associated with liver disease, or acute blood loss, or rapid cell breakdown, our body's going to compensate by releasing more of these reticulocytes, leading to a reticulocytosis. Our third classification of anemias is going to be our normocytic normochromic anemias. These types of anemias have a normal MCV and a normal MCHC. So again, our cells are going to be normal in size with an MCV of 80 to 100 femtoliters. Our cells will have a normal color, so our MCHC will be 32 to 36 grams per deciliter. Although there's a normal size and a normal color, we still have anemia, meaning we have a low hemoglobin. And although the patient is anemic, all of their cells are absolutely normal in terms of morphology and in terms of their MCV, MCHC. So what might cause a person to be anemic even though they have normal red cells? Well, sometimes it's not the cells themselves that are the problem. There's nothing wrong with the cells. It's just maybe you have too few of them. So if you think about it, pancytopenia or decreased production of all three cell lines would lead to anemia simply because you don't have enough red cells in this case circulating and carrying the oxygen. And one of the things that can cause this pancytopenia or this decreased production in all of our cell lines is aplastic anemia. Aplastic anemia is essentially where we have dysfunctional bone marrow. And instead of that nice red hematopoietic red center, we have primarily yellow marrow, which is made up of fat. So remember, red marrow equals a cellular part, and then, red marrow equals a cellular part, and then we have that yellow marrow, which is fat. Now, it's normal to have some percentage of fat present in the bone marrow. That's totally normal. And it increases with age, but there are some people who, for some reason, have a depression of that bone marrow capability. They have more fat than they should, and fewer hematopoietic centers where red blood cells, white blood cells, platelets are produced. And patients who have that increased yellow marrow have something called aplastic anemia. With regard to aplastic anemia, we really have two classifications. We have acquired and constitutional or congenital. Now, the most common type of aplastic anemia is idiopathic. That just means we don't know what causes it. We don't know why someone develops aplastic anemia. There are some secondary acquired aplastic anemias that are due to exposure to drugs, radiation, and infection. For example, the antibiotic chloramphenicol has been banned in the United States because it has been shown to lead to bone marrow suppression and therefore leading to aplastic anemia in some patients. And so there are some type of exposures that can do that. If you think about radiation, obviously that's sometimes used therapeutically to decrease production of cells, not necessarily in the bone marrow, but maybe in terms of malignancy. But yeah, it can affect bone marrow as well, and infection. can also cause that. Now, with regard to congenital forms of aplastic anemia, we have something called Fanconi's anemia, and then we have another type of aplastic anemia called familial aplastic anemia. And those are both inherited, obviously. So some of our clinical findings that we may see in a patient with aplastic anemia is we may see bleeding with petechiae due to those low platelets, because remember, we have pancytopenia, which means not only do we have a decreased red cell count, but we also have decreased whites and platelets. Obviously, we're going to have that anemia simply because of the lack of red blood cells that are in circulation. We might also see infection due to that low white blood cell count. And um, but we're not going to have any hepatosplenomegaly or lymphadenopathies. So our spleen and liver and lymph nodes are not going to be affected by this. Okay, so below you will see two pictures. The picture here on the left is representative of a patient with aplastic anemia. And then here on the right is a normal cellular bone marrow. So look at this red or purple area. These are the hematopoietic centers or the cellularity of the bone marrow. And then these white areas are yellow marrow. They are made up of fat. And then over here you see primarily yellow marrow. This is just all fat with a few tiny little hematopoietic centers here. So if you think about this bone marrow, it only has very limited supply and capability of production because the hematopoietic centers are decreased. Um, so if this patient has a hypocellular bone marrow, we would see this in a bone marrow biopsy. We would also see that peripheral blood showing pancytopenia. And the most important thing is we would see greater than 70% fat within that bone marrow. And that's what we would consider to be hypocellular bone marrow. And then of course here we've got a normal looking bone marrow. So the biggest problem with patients with aplastic anemia is number one, sometimes we don't know what causes it. In fact, the majority of the time it's idiopathic. And number two, they're very, very susceptible to infection. And in fact, most people with aplastic anemia, um, if they pass away, it is usually due to infection. However, treatment for people with aplastic anemia is usually in the form of bone marrow transplants, and immunosuppression offers 60 to 90% of patients with at least a 2-year survival. I don't know about you, but 2 years doesn't sound very optimistic to me. However, I will say that what we do know about bone marrow transplants for aplastic anemia is there's a much, much higher success rate in younger people with bone marrow transplants than in people who are older. And I think that might be in part due to as we get older, we tend to have less functional bone marrow to begin with. Um, so obviously, if you are younger, your prognosis is typically better with a bone marrow transplant. So there are a couple of other types of aplastic anemia, just because I want to mention them. We have pure red cell aplasia. This is usually acquired due to an infection. And there's a congenital form called diamond black fan anemia or DBA. And I'm not going to go really into depth. I really just want you to know that there are different types of aplastic anemia and kind of just a very brief overview of them. We're not going to go into the pathophysiology of each one. Um, the second type is congenital dyserythropoietic anemia, which is essentially an abnormal and ineffective erythropoiesis characterized by multinucleated red blood cell precursors. So something is going wrong during the erythropoietic process. And then, of course, we might see bone marrow that's normocellular or hypercellular, but peripheral blood that is pancytopenic. And that's because um, along with that dyserythropoietic process, those cells do not make it into circulation because they're dysfunctional. And so they kind of have a shortened lifespan. So anytime we have a problem with production or development, most of those cells do not actually function properly. And therefore, we might see hypercellular bone marrow, but pancytopenia in that peripheral blood. And of course, you guys all know how much I love a handy dandy flow chart. Um, we like to categorize easily our microcytic anemias, our normocytic anemias, and our macrocytic anemias based on our MCV. And then the different types of things that could cause that or different conditions that could be classified under those categories. All right. I do have a flow chart in your files that I want you to fill out. We'll go over them in class, but make sure you're able to easily recognize what type of anemias fall under which category in terms of the MCV. So which of those anemias are typically microcytic, which of those anemias are typically normocytic, and which are macrocytic. Okay? All right, thanks for joining me on this lecture. We will talk more about it in class. Bring your questions and I will happily answer them. Have a great day.